Dharavi, Hindu by religion, right-handed, brought by mother with complaints of vomiting since 10 days, difficulty in walking since 4 days, and change of voice since 4 days. Vomiting since 10 days, 8 to 10 episodes per day, small in quantity, non-bilious, non-projectile. Vomiting since 10 days, 8 to 10 episodes per day, small in quantity, non-bilious, non-projectile, containing food particle, predominantly after meal, associated with headache, generalized, dull aching, relieved after vomiting, recurrent. Vomiting since 10 days. Am I audible?
Hello, yeah, ma'am, you are audible. You are audible. Ma'am, we cannot hear you now. You are not audible now. Hello?
Hello? Hello?
Yeah, now you are audible.
Okay. Uh, Vomiting since 10 days. Am I audible?
Yes.
Hello? Hello?
We
Am
can
I
hear
audible?
you. Yes.
Hello? Am I audible?
Yes, we can hear you.
A 9-year-old boy, third by birth order, born out of non consanguineous marriage, residing in Dharavi, Hindu by religion, right handed, brought by mother with complaints of vomiting since 10 days, difficulty in walking since 4 days, change of voice since 4 days. Vomiting since 10 days, 8 to 10 episodes per day, small in quantity, non bilious, non projectile, containing food particle, predominantly after meal, associated with headache, generalized dull aching, relieved after vomiting, recurrent, not associated with blood in vomitus, not associated with pain in abdomen or loose stool, relieved after some oral medications, no episode of vomiting since last 2 days. History of recent travel from village, post traveling vomiting episode started. Since last 4 days, child was having difficulty in walking, noticed by mother, initially not able to bear weight on legs in upright position, but able to walk with support, frequent falls without support, progressed over 4 days to not able to walk with support, associated with pain in legs below knee. However, child was able to lift the hand above the shoulder and hold objects. A child was able to turn side to side in bed and get up only with support from blood. Change in voice since 4 days in form of nasal twang and low volume slurred speech. There is increased history of increased chewing time, difficulty in swallowing, and decreased oral intake. History of fever for 3 days, 2 weeks prior to the onset of weakness. No history of altered sensorium or seizure. No history of any involuntary movements. No history of abnormal eye movement, vision abnormality, or hearing deficit. No history of sensory deficit. No history of bowel bladder involvement. No history of animal bite. No history of recent vaccination. No history of drug or toxin intake. No history of trauma. History of Cox and elder sister 8 years back. Peripulmonary TB taken in 6 months of AKT. Past history, multiple admissions between 2 months to 3 years of age for recurrent LRTI, required NEPs, told to have asthma, given MDI for 6 months. Antenatal history uneventful, birth history uneventful, immunized till date as per national immunization schedule. Developmental history goes to school in third standard, good scholastic performance. Dietary history, calorie deficit of 235 and protein deficit of 3.6. Uh, Family history, there is no significant family history.
Hello. The chief complaint is vomiting since 10 10 days, 8 to episodes, and the other details which are. So, what does it tell you? When somebody complains of vomiting, a few things come to our mind. The first thing is to decide what system it is likely to be. The commonest thing that we will think of is likely to be the GI system. So, what are the peculiarities of GI system? In GI system, what the vomiting could be? Esophageal, stomach, or lower down in the intestine. So, what are the peculiarities of vomiting if it is due to esophageal cause? Because the higher up if you go, there will be no vomiting. Suppose there is some pharyngeal problem, there will be more of dysphagia rather than vomit. So, is vomiting means it's coming from something below the throat. So, esophageal vomiting. We can take one case of esophageal vomiting you may have seen. Say chalazia achalasia. So what are likely the features of chalazia achalasia? What is the timing of vomiting after the child or adult eats? Almost immediate. Okay, it hardly has time to go then. And sometimes there is more vomiting for solids and sometimes the more vomiting for liquids depending upon the cause. And is it ever bilious? Never bilious because it's coming from. So vomiting is soon after a feed, almost never bilious. Sometimes depending upon the disorder, it may be more for solids or liquids. Pain is often another symptom which you must think of. Where is likely to be pain if it is esophageal?
Gastric
Yeah,
region.
retrosternal. It may be related to. So likely to be retrosternal soon after a feed. There may be relief after vomit. This is another thing important. Is there a relief after vomiting or it's worse after vomiting? It's likely to be a relief after vomiting. Okay. And then of course general symptoms may be loss of weight, etc. etc. So are these symptoms related to or suggest an esophageal vomiting?
No, sir, not esophageal.
Probably not. Okay. Non-bilious happens soon after food. There is no complaint related to retrosternal nor immediately after food, or dysphagia either for liquids or solids is not there. Stomach. In esophageal, you may consider the lower esophageal problem also, in which case, like in the malarivis, there may be blood stain vomiting, severe, which it is not there. Come to the stomach. Peculiarities of gastric vomiting.
It is non-bilious, non-projectile.
Non-bilious soon after food.
Epigastric
It
pain
may be
will be there.
projectile, may not be projectile. Epigastric disturbance, but pain. Pain is going to be a feature. So epigastric pain may be relieved, may not be relieved afterward. Almost never bilious. Soon after, it may be equal for solids and liquids also. Is there anything to suggest gastric cause? I would say pain should have been there if the child has been vomiting for such a long time, 8 to 10 per day. I would expect some epigastric disturbance or pain. It may be worse after vomiting, it may be better after vomiting, the pain, but there is nothing that suggests that this particular vomiting has anything to do with food intake. Am I right? Okay. Then you come to lower down. We are considering GI system as a cause of vomiting, which should occur to our mind first. Intestines. What is a prototype which you'll remember? You think of hypertrophic pylori stenosis, progressive vomiting, bilious, or intestinal. And then intestinal, you know that below the ampulla of Vater and below the ampulla. So if it is below that, then bilious vomiting, persistent vomiting, and there may be again abdominal pain as a feature. Here in your case, never abdominal pain has appeared as a feature. Child has vomiting 8 to 10 times a day, but no abdominal pain. It is soon after food, but nothing to do with that. Some GI must have some. Suppose it is something like a diaphragmatic hernia, which is not really an obvious cause. Even then, some discomfort has to be there. Relation to food is also another important. Here you have said that it is soon after food, but no pain, no discomfort, no. So I think GI, maybe we'll keep it at the back of mind. It doesn't fit in well with neither esophagus, lower end of esophagus, stomach, below and above ampulla of Vater, or outside the GI system like we consider. Okay, what other system may be involved in GI system? Vomiting.
CNS can be there, but
Okay.
projectile vomiting will
So
be there.
if it is CNS, there has to be projectile vomiting. Well, we will keep that in mind. I would say if it is projectile, it helps. If it is non-projectile, I will not rule out a neurological cause definitely. But there is something which you have written here which directly points to a neurological cause. And what is
Headache.
that?
Headache.
Headache, yes. Associated with headache, and the next line is important.
Relieved after vomiting.
Yes, there is headache associated with that, so it brings us to a neurological problem. But a headache which is relieved by vomiting is much more likely to be neurological. What is the simplest or the most common example?
Migraine.
Migraine. But is it migraine?
The
8 to
episode
10 times a day, significant pain, just going on for 8 to 10 days. And even if it is so 8 to 10 days, we may not consider a diagnosis of migraine, though it is relieved by, and if it is relieved by vomiting, then the migraine should subside. So migraine, perhaps no, but vomiting is likely to be neurological, more likely to be just by the simple fact that persistent vomiting relieves it is associated with headache, and persistent vomiting is relieved by, or rather the headache is relieved by vomit. Okay. Any other system? Urinary tract infection? Anything? Can it give us what what will produce vomiting in urinary tract system? With a small child, UTI can give rise to vomiting, but there is associated fever. So there is no fever here. So probably not. Anything like liver disease can produce vomiting. Why not? Is it a liver disease?
No other features like jaundice, yeah, bleeding manifestation is not.
Anorexia, jaundice. And if this child has been vomiting due to liver disease for 8 to 10 days, other symptoms of liver disease should have come by now, either in the form of jaundice or in the form of altered sensorium if he is going for prehepatic or hepatic encephalopathy, some alteration in the sensorium. But within 8-10 days, liver should have shown the other signs. Also, there should have been some anorexia or other symptoms related to vomiting if it was of a long standing duration. Can it be a metabolic disease like a Wilson's disease, which is a cause of liver disease and producing vomiting? Occasionally, Wilson's can present as a relatively acute disorder, but if it has present within 8-10 days, by now in 8-10 days, he should have gone in for any. So any persistent vomiting 8 to 10 times a day due to liver disease going on for 8 to 10 days, by then hepatic manifestation, or for that matter any other abdominal pancreatitis etc. should have come. Hypertension,
Hypertension.
possible. Severe headache and vomiting, and here also vomiting is likely to give rise to relief of headache. Therefore, hypertension may have to be considered as a part of it. Now, why should 10-year-old child get hypertension? Maybe primary, but maybe as a result of some urological disease, kidney disease, which has been there for some time. And now, as a result of chronic renal disease, he has got the vomiting as a hypertension and vomiting. But I thought 8 to 10 years was too little short a period for chronic kidney disease to have presented with vomiting. Though I had seen atypical HUS in one child where vomiting was the main symptom in this child and significant hypertension and not too many. And he was just 12 or 13-year-old child. So some urinary symptoms should have come by now, but we will keep that also in mind. So hypertension may be primary or may be related to a urological disease. Then we saw the neurological endocrines.
You can also have other symptoms of
Such as
uh,
acute adrenal failure, vomiting, but in 7-8 days of vomiting, he would have gone in for shock, significant deterioration in the condition of patient. So less likely he would have gone for other manifestations, anything which will produce hypertension of adrenal origin would come back to again hypertension as a cause. There may be other symptoms. So I think hypertension we will not keep out of our mind.
Madam,
Hypertension, though
madam,
I don't know whether relief of
oh madam,
headache will come with vomiting. In a
आ
case
गए
we keep hypertension, and when we keep up
देखती हूँ
hypertension, we keep other causes of hypertension,
लग गई
the endocrinal and of course urological. But we will boil down to either a CNS cause because the vomiting is relieved by, I mean the headache is relieved by headache. And headache and
हाँ
vomiting
यहाँ से लेफ्ट
together
ऐसा दिखा रही है
first point to a neurological cause rather than so neurological and hypertension are two things which are at the front of our mind, and GI and other disturbances are not so considered, though manifestations are GI manifestations. Then what is the next thing? No blood, no abdominal pain. You have mentioned all that. History of recent travel from village. Oh, there's something. No evidence of vomiting in last 2 days. Vomiting is relieved by last. What is that likely? Without treatment or with treatment?
oral medications.
Some oral medication name. So we don't know what that medication. A temporary relief may have been there with either the painkiller or by chance somebody has accidentally checked the blood pressure of the child and treated with antihypertensive. It's less likely. Only symptomatic treatment may have given relief from the vomiting. Significant hypertension related vomiting coming under control with just simple analgesic is less likely. But neurological vomiting may be related to increase in intracranial pressure, relieved by or migraine, that kind of thing, relieved by pain is likely. So 1 or 2 days of medicine. So we are keeping both the things in mind, but we are thinking more in terms of neurological. And then since last 4 days, child was having difficulty in walking. Yeah,
Getting acute onset vomiting in a healthy 10-year-old child, if it persists beyond 2 days, it is never GI. Make it a rule. Okay. Gastrointestinal infection, intestinal obstruction, everything should be clear by day 2, day 3. If it persists, then you know that it's unlikely to be GI. Well, as a rule, you could say that there could be severe esophagitis. Well, it's not vomiting alone then. You have some burning pain. Okay. So if you have no clue in the first 48 hours and the vomiting is significant, it is always non-GI, till proved otherwise. Then it's acute. Acute is never renal. Even acute hypertension does not cause vomiting. It's a chronic, slowly progressive vomiting in an adult that may end up, but otherwise, an acute hypertension severe enough would have many other symptoms, including vomiting. But this child has come only with vomiting. So to me, hypertension is out. Okay. Acute liver, it would have had jaundice, whatever the cause, including Wilson's. Wilson can present with acute jaundice, acute hepatitis like, but jaundice is a feature. Vomiting is not a major complaint. So here, vomiting is a major complaint. So almost all systems are ruled out, except CNS. Now you have a headache too, so that becomes very easy. But I want to make a point here that many times the slowly coming up raised ICT may have headache only in the morning on waking up. And that the parents might not talk about it because there is no headache significantly. Morning he has a headache, then the whole day is all right. So also remember to ask for a morning headache on waking up and thereafter is all right. So the symptoms told to you are mainly vomiting. You need to ask about headache and also make sure it's not a morning headache to begin with. This was not. This was together. So this is not acute onset headache, vomiting. So acute onset raised ICT. Okay. Why should acute onset raised ICT come up suddenly? So you have a past story of fever. This is certainly not acute meningitis, encephalitis. This is not a brain tumor. Okay. Could it be a sudden acute vascular episode and cause vomiting? Now we know it's an acute neurological disorder. It's not infected. Could it be vascular? Stroke, for example. Do you think stroke can cause vomiting?
10-year-old child having acute onset stroke is without any previous history.
Persistent vomiting is not a story of a acute arterial side infarct. If it was an acute venous infarct, there could be buildup of raised ICT, but there will be a change in sensorium, maybe seizures. So again, this is not vascular. Could it be metabolic? At 10 years of metabolic acute onset is very unusual. But had it been 6-month-old, yes, I think that would have been way up on the path. So now non-infective, non-metabolic, non-vascular, reverse fever, acute immune mediated. Okay. And right at that stage, and that is the way the vomiting has now disappeared. Has the headache also disappeared?
So,
Yes, both are disappeared. What does it mean? It's a transient vomiting and headache. The disease continues to manifest further, but the major symptoms that started with are already gone. which means the raised ICT is gone, but the remaining damage has come up. So that clearly means that it is an acute immune-mediated encephalopathy, which seems to have come under control either naturally or with steroids or whatever. And now we have a neurological symptom coming up. Till the vomiting disappeared, we would not have been sure whether it will disappear or not. It might even get worse over time. But the story is running a little longer time. It is not typically an acute immune mediated encephalitis like NMDA. It comes little faster with maybe seizure, maybe encephalopathy. So this slowly coming up raised ICT. And I think that is.
Yes, sir, completely. The only challenge here is that when you expect a CNS condition, you look at CNS problems and not look at general complaints. And when, as sir said, if general complaints continue beyond the stipulated time, then you need to look elsewhere.
Now, last 4 days, child was having difficulty in walking, noticed by the mother. Just one word about vomiting and early morning, not related here. Migraine vomiting is never worse in the morning. It is relieved by rest. Therefore, vomiting comes later in the day, and hypertension is always worse in the morning. So, diurnal variation can help in distinguishing. Now, coming to since 4 days, child was having difficulty in walking, noticed by the mother. Initially, not able to bear the weight on the legs in upright position, but able to walk with support. Frequently falls Frequent falls without support, progressed over 4 days, not not being able to walk with support, along with pain in the legs. Let us start with, suppose the same child comes to you with whatever difficulty in walking noticed by the mother, and he was not able to bear the weight on the body. So difficulty in walking with not be able to bear the weight means what?
The child cannot uh, walk very long distance. The child look after um, 2 to 3 steps he will and he has frequent falls like he will bend on his knee.
So there may be many causes of not being able to walk. Here, the child is not able to bear the weight of the body, and therefore he is not able to walk. That's what we have said. That means what? Weakness. The power is affected, at least as suggested by you here. It's not, say, lack of balance or ataxia or anything. So maybe lack of power. Can it be alteration in the tone that may be? Why not? And hypotonia, yes, but spasticity or rigidity, no. Number one, it may not come so acutely. And secondly, he may still walk, but with difficulty. Okay. So acute onset spasticity would come little later. Even in a spastic disorder, initially there may be loss of power or hypotonia, and later on the spasticity will develop. So if he is not able to walk, that means the power is affected or tone is affected or both are affected. Now, whether both are affected simultaneously, that means both the legs are affected or leg is affected, well, how do we make that out? If one leg is affected, what will be the walk? If both the legs are affected, what will be?
Gait will be different if only one leg is affected, and if both the legs are affected, then the patient cannot walk
If
only.
the history is correct and mother's interpretation is correct, if there is one leg affected, he'll walk with a limb. He may try to walk, but still walk with a limb. If both the legs are affected, he is not affected. Depending upon the power and the tone, the extent to which initially there may be little attempt to walk and he may sit down or he may not be even able to get up. So your history tells us difficulty in walking noticed by the mother, initial not able to bear the weight, suggests power or tone or both on legs in upright position, but able to walk with support, frequent falls without. So able to walk with support means what? The power was not decreased so much that he could not, and with support, maybe the person who was supporting was only bearing most of the weight of the child, and he had a continued weakness with that. Again, power or tone, perhaps both the legs. Okay, so bilateral, lower limb, weakness or hypotonia or both. Okay, position able to walk, frequent falls. Falls were without support because he was not able to bear. He is bound to fall. Can the fall be neurological? Seizures and fall?
So sensory.
Probably no, because if there was a seizure with fall, he would not have come with difficulty in walking and not able to walk. A fall like, sudden episodic epilepsy or something like very unlikely. So they were due to related to lower limbs only, hypotonia and weakness or both related to both the legs. Whether they were equal in both the legs or no, we don't know. Maybe at that time you would have asked the history whether they were associated bladder bowel disturbances as well, because bringing of bladder disturbances, now we are taking us away to a spinal cord. So there were no bladder bowel disturbances perhaps at that time. Progressed over 4 days to not being able to walk with support and associated pain in the legs below the knee. What does that tell you? Progressive weakness. Progressive weakness of both the legs associated with pain. So progressive weakness can be as a result of anterior horn cells, the roots, the myoneural junction pain as we normally do. Now, here the pain was associated with pain in the legs below the knee. Pain is feature of what? It could be as a radical, not per se because of the spinal cord. It could be as a result of radical or peripheral nerves. Can it be as a result of myoneural junction or pain in the muscle? Muscle maybe, but muscle pain or myositis presenting like this is uncommon. And often in children, they have dermatomyositis and not of acute duration. So maybe radical or peripheral nerves. We don't know about the symptoms associated, sensory symptoms also. So he probably had bilateral lower limb weakness, maybe with hypotonia, perhaps of radicular origin or peripheral nerve origin. So we are now coming to a neurological disease, the central neurological disease, with manifestations coming down. Once we had thought of meningitis, there is localization there, and now there is a localization here also. Can this explain that? Can the central nervous system explain his weakness down below? But
Peripheral nerve.
peripheral nerves, yes, but a person with peripheral nerve has no business to get increased intracranial pressure. So if there's an increase in intracranial and lower down, and if I'm not able to explain the lower limb weakness with increased intracranial pressure, if there was anything, then it would have produced spasticity and toe walking. That also not also. So I think the headache and the raised intracranial pressure and lower down neurological, but probably not one related to other. That means it is, what does it tell you? It's a diffuse disease. It's a diffuse disease involving central nervous system as it may involving that. It is symmetrical, perhaps, but we don't know that. I would have expected an asymmetry in this child. So the symmetry, because symmetry is going to point out most of the time with spinal cord, but we don't know about asymmetry. But there is enough. Then after that, however, child was able to lift the hands above the shoulder, so good power against gravity, and hold object till child was able to run side to side in bed and getting up only with support from the bed. So he was so above the shoulder, hold object with hand. You may also say that form object, reach for an object and hold the object in hand. Therefore, ruling out involuntary movement. Holding objects tells you the power and tone in the upper limbs was all right. And able to run side to side in bed. Acha, turn side to side in bed. So probably the axial muscles were not involved, because if the axial muscles were not, like for example, a CP, when the axial muscles are involved, then turning from side to side is affected. you ask, right? Not able to.
Because if whether um, upper limbs and the upper muscles are in. I want to rule out the upper limbs and upper muscles. Respiratory
Specifically
muscle,
choose, yeah, very good. Which respiratory muscle?
the diaphragm.
The diaphragm, correct? So diaphragm and the abduction at the shoulder are both supplied by the same nerve root. So if you are thinking of a pathology which is a radiculopathy, then or some spinal cord, spinal involvement, then you want to use this as a surrogate marker to identify and proactively treat a diaphragmatic weakness.
And also, there was no difficulty in swallowing. You not mentioned that perhaps, but difficulty in swallowing, breathing, etc., may be important because we also want to consider the lower cranial nerves, upper cranial nerves, because we are somewhere here in the central nervous system. We are coming down below to different areas, patchy involvement, symmetrical or asymmetrical, I don't know. Associated cranial nerves and ataxia and all those organs which are there, basal ganglia, etc. History related to that may be important. Was there anything like that here?
History of
Or change in voice for 4 days, nasal twang,
nasal.
and low volume slurred speech. So it is there what we thought may be there. So the lower cranial nerves are affected. Swallowing, so 8, 9, voice is affected. Voice may not be related to cranial nerves, but the strength of voice is affected. What does it mean? It may be not so much of cranial nerve support, third is ninth is affected. There may be nasal twang. If the power of the voice is going down, that means the skeletal muscles of intrathoracic or the diaphragm is getting involved. Because when I'm shouting at you, I'm breathing completely and using my exhaled motion to shout loud. If the power has gone down, I think something is happening to the respiratory muscles as well, as Dr. Tushar just said. Maybe intercostal, it may be more like diaphragm, and we keep in mind. So, neurological involvement, higher up, lower down, and also maybe respiratory. Patchy, one cannot explain the other. Okay, patchy, and therefore we are coming down to patchy neurological disease of acute onset involving the sensorium to a certain extent. At least the meninges, his sensorium is not affected so far. Cerebral cortex is not affected. His understanding and all this has not affected. Only maybe raised intracranial pressure in this particular child that we saw. Why there should be raised intracranial pressure without any other problem, one wonders why. Because I would have expected something to be there in the higher system, some neurological, some cerebral, somewhere it is there. Only raised pressure and lower down. And lower down now, progressing from lower limbs to upper limbs, patchy or maybe progress. Okay, it may be patchy or progressive. So if we say history of increased history of time, difficulty in
wing and
difficulty in
decrease
swallowing. So increased chewing time and difficulty swallowing does tell that the lower cranial nerves are also affected. Voice may not be so much affected because there will be change in the type of voice, but the power of voice is affected. Then it is less due to central, the lower cranial, and maybe maybe more related to respiratory muscles. Difficulty in swallowing, definitely lower cranial. Decreased oral intake, maybe as a result of difficulty in swallowing. He doesn't want to. History of fever for 3 days, 2 weeks prior. Okay, so there is some history of fever 2 weeks back. At that time, if somebody had brought the child, we would have said, "Do din ka fever hai, kyun laya?" An intervening period. Now that we have so much of this, an intervening period is normal, and there was fever for 2 days, we would like to take the help of that 2 days fever to explain that. fever, then an interval asymptomatic and onset as so immunological disease with an interval in between, which was so to say silent. So immunologically mediated neurological disease may be patchy, involving lower cranial nerves, lower limbs. I don't know, I'm not very sure about the respiratory muscles involved. I'm not able to explain the raised intracranial pressure, which we diagnosed in the beginning with only based on this. And I don't know, that maybe encephalopathy or increased, so to say, exudates giving rise to encephalopathy, therefore raised pressure, but no localization. This is what will bring the time. And then depending upon that, whether it is ADEN or whether it is polyneuropathy coming up one after the other. In polyneuropathy, initial CNS symptoms perhaps are less likely. But the progress of the illness is like that. Started from lower limbs and came to the cranial nerves, maybe respiratory thing, or maybe CNS patchy involvement. That's what will come down. Histiococcus in elder sister 8 years back, and pulmonary TB taken 6 months back. This girl has taken anti-TB treatment 6 months back. Elder sister. This child's age is 6 years, 10 years. The older sister took the treatment 8 years back. So this young lady of 10 years, or whoever that man is, has come in contact with the sister when this child was 2 years old. So if he got tuberculosis at the age of 2 years, and that the child managed the tuberculosis for next 6 years without getting symptoms, she has got tuberculosis when she was 2 years from the sister, if she has got it. And she managed well in the most vulnerable period of that time and has manifesting after 6 years. So tuberculosis is probably not the cause in this one. Well, reactivation should have taken a little longer, slowly progressive disorder, that this child has not been keeping well for 2 months, and there is fever and slowly progressive headache, etc. So good that we got a history, but 8 years back, I mean, not likely. The child got, if at all, got tuberculosis when he was most vulnerable and didn't manifest like that. So no tuberculosis in this particular child. So this is perhaps, these are one of the two of the things possible, either GBS or ADEM. Perhaps ADEM more likely than GBS, because raised intracranial pressure should not occur with GBS perhaps.
I think when you said that the vomiting was 10 to 12 times a day for several days, there would have been some evidence of a behavior change, drowsiness, okay, lethargy. Maybe might have attributed to severe hypotonia, the hyponatremia, but there could have been such thing. Now, retrospectively, we could ask the mother whether during those times, you said every time ingested food came out, how did the child manage to reasonably survive normally for 6, 7 days? So possibly there was some behavior change, etc. And that's why encephalopathy. But I want Tushar to react to what I'm saying, that I know the peripheral nerve that you are talking about slowly going up has autonomic nervous system dysfunction. But I thought it is not continuous or going on for 6, 7 days. But I thought it was transient. Am I right on that?
So if we are talking about polyradiculopathy, then associated with that, if you are saying autonomic nervous system, to start only with an encephalopathy like picture, then there is that Bickerstaff variant which is there, which generally doesn't come with, when it comes with encephalopathy and peripheral nerve. Here our encephalopathy is not very prominent. So we still need to figure out where we fit it. The other important point is when we get history of pain below the knee. Classically in GBS, where is the pain? Lower back. And which test do you do to elicit straight leg rest? Very good. So that does not look for pain below the knee. If there is a pain below the knee, either as sir said, there is a particular radical pressure, or there is some other reason for it rather than just a standard GBS. And as you mentioned, GBS, polyradiculopathy related pain is transient. It comes and it goes away in few days by the time the disease progresses.
To make a similar situation, which is not this, that if you have a slowly raised ICT and then the patient finds some difficulty in walking, it could be a hydrocephalus developing, and the story with upper motor neuron, lower limbs could fool us exactly. This is too short a story, so we are not considering that. But that's another thing to keep in mind. Hydrocephalus with difficulty, and typically the aqueductal stenosis slowly coming up would present exactly like this, right?
One more interesting point here, what does not fit in the typical picture, probably is that you have a progressive weakness, almost symmetrical on history at least, of lower limbs going upwards, right? Correct me if I have not understood it correctly. Then your axial tone is, the child's axial tone is reasonably preserved because he is able to turn around. And your shoulder movements, hand movements, and you have not said anything much about the fine motor movements. So all of them are normal. And then you have a problem with chewing and problem with voice. So if this is a situation, hypophonia per se is less likely. But if you are telling me that there is hypophonia versus nasal twang, these are two different things. Hypophonia, as sir said, is because of lower capacity, less tidal volume, lower muscular capacity. One is not able to exhale out enough, and then there is hypophonia. That would take me to again T4, T5, C4, C5. But if it is chewing difficulty, swallowing difficulty, and nasal twang, then it takes me to a bulbar, pseudobulbar level. So that is where the difference is going to come. And if you have a situation like this where there are patchy or non-continuous areas which are affected, you have two situations. One, you are talking about edema, for which technically encephalopathy is required, or you are looking at a variation of demyelinating condition where you are thinking in terms of GBS variant, or no, poliomyelitis or polio-like illness we are not talking about, because there again this, as you said, it's just start with pain, then inability to move, etc. Right? You are talking about like transverse myelitis versus NMO versus whatever. So they have those patchy lesions, and you can have different segments affected with sparing of segments in between. So that is where you can explain variables. I'm not saying it looks like this here, no bladder bowel involvement and no sensory involvement, etc., etc. But this is how one would evaluate and differentiate.
There are some multiple admissions. Acha, between 2 months and 3 years of age, LRT. So you gave some provisional diagnosis as well. Did you change your provisional diagnosis after the final diagnosis came?
No, sir.
So you should persist with, because whatever you thought is right or wrong is not important. Analysis is important. So if you persisted with that, I'm happy.
A 9-year-old boy with a complaint of vomiting, difficulty in walking, and change in voice with swallowing difficulty without any involuntary movements, without bowel bladder involvement, with normal birth and development history in fully immunized child is probably a case of acute onset progressive motor weakness. My DDs are GBS, transverse myelitis, peripheral neuropathy, poliomyelitis.
Just one small point here from exams. India is proudly polio free for many years. So please don't put poliomyelitis as a differential diagnosis, like saying smallpox, almost. So say polio-like illness, right? Because unnecessarily the discussion will go on that and you may not be prepared for it. Polio-like illness is fine because you have enterovirus infections which present like that, whatever. So that is still okay.
On examination, the febrile heart rate was 100 per minute, RR 24 per minute, saturation 98% on room air, peripheral pulses well felt, extremities warm, BP 100 by 70 millimeters of mercury, which is in 50 to 90th centile, no pallor, icterus, clubbing, cyanosis, or lymphadenopathy or edema, and
Cardiorespiratory problems so far.
no, sir.
Heart rate, blood pressure, circulation, respiratory rate, everything, and work of breathing, there's nothing like that. So, not really.
Anthropometry, weight 23 kg between -1 to -2 standard deviation, height 120 centimeter between -1 to 0 standard deviation, BMI 14 between -1 to -2 standard deviation, impression normal, head to toe normal examination, skull is normal in size and shape, oral cavity normal, chest, abdomen, spine normal, no neurocutaneous markers. Systemic examination, central nervous system. Child is awake, conscious, oriented to time, place, person. Cranial nerve examination. Both pupils round and equally reactive to light. No tosses or squint. Bilateral loss of nasolabial folds present. Cannot close eyes tightly. There's no hearing abnormality. Gag present. Uh, can turn face on both sides and no tongue deviation. Examination suggestive of, and there is examination suggestive of bilateral element type of facial nerve. Uh, cannot blow the yeah, the child cannot.
How do you know it's lower motor neuron?
Bilateral and lower involved.
Mhm.
So the
And
upper
in
face and lower face.
and in
also
bilateral upper motor, the upper part is preserved.
bilateral.
No, it's not
Yes.
preserved. That's the problem. No? That is the problem when you have bilateral lesion. There is another way of checking upper motor versus lower motor. Anyone? So please correct if I'm wrong. How do you differentiate bilateral upper versus the emotional content is intact in the lower motor neuron.
And also with bilateral upper motor, lower down also maybe, limbs, etc. Yeah, then only based on that. Okay. Yeah.
Cannot open the eyes when
He can close the eyes, but he cannot close
he
it
cannot
forcibly. You can open it easy.
the tone is normal.
So, but third, fourth, sixth is not affected.
Third
Yeah.
person. No, sir, that was not. The tone is normal. Pa-
Because now you have lower facial and everything else. But if suppose you had only eye and the nasolabial and other things were not so prominent, sometimes it's important to be able to differentiate bilateral ptosis versus bilateral inability to close the eyes tightly. Okay?
there
Not
will
in this patient, I'm saying in general.
uh, the child cannot smile also. The tone is normal. Power in upper limb 4 by 5 in both upper limbs and 2 by 5 in both lower limbs. Reflexes knee, ankle, and biceps reflex absent. Triceps reflex 1 plus in both left and right. Plantars not present. Sensory examination normal. Meningeal signs absent. No cerebellar signs. Bilateral straight leg raising test positive. Respiratory system, rest of the system normal. And summary. 9-year-old boy, case of vomiting, difficulty in walking, and change in voice with bilateral seventh cranial nerve involvement, without involuntary movement, without bowel bladder involvement, with absent reflexes in lower limb and diminished reflexes in upper limb, with normal birth and development history. In fully immunized child is a case of acute onset symmetric flaccid paralysis, most probably GBS.
How would you explain the initial vomiting going on for 10, 15 days with headache?
It can.
Suppose you say autonomic disturbances for 15 days, hypertension as an hypertension as an autonomic disturbance, not acceptable. GBS that we see classically starts presenting with lower limb paralysis, goes on ascending. But if we say the initial CNS symptoms, which were not for a short time, almost 15 days, and vomiting, and relieved by headache, relieved by vomiting. I mean, you can't entertain migraine as another diagnosis. So I think that needs to be explained on the basis of. So there, one would expect a patchy disease. There may be something here, but I cannot adequately explain what is going on. So maybe with the race pressure. If you can say GBS with race pressure. So what is it? GBS with race pressure means kaun sa disease?
So one more question I have here. First of all, cranial nerve affection in GBS is not uncommon but not common either. Okay. The problem is if you get cranial nerve involvement, it's usually late and usually after a severe disease or it indicates a severe. The second point is the signs that you said about nasal twang and low voice, etc. Gag was still present. If gag is present, then nasal twang is not related to the palatal palsy. That means the ninth cranial nerve is not up because that's your physical evidence. Nasal twang can happen with nose block also. So that is a separate story. But if you get a gag positive, then definitely you are not looking at a vulvar involvement. So then why is the baby, why does the child, and respiratory you have demonstrated that the shoulder is normal and abdominal movements, saturations, everything else is normal. There's no tachypnea, RR is normal. So why is there low voice? I'm just telling you that that is something that does not fit with her. We don't have an explanation for that. Thank you.
Over the course in ward and PICU, the child had a weak gag over the time, but on presentation, the gag was present.
I'll discuss something once we are offline.
You are allowed only 1 minute.
None.
Serum electrolytes. Sir, MRI was.
No, you go ahead.
Yes, sir. The CBC. Sir, actually, MRI was not done. NCV test was done and the report was awaited, sir.
Okay.
Orally, they have told GBS variant, but the report. CSF was not done, sir. CBC, WBC count 12,000, HB of 14, HCT of 43, and platelet of 4,12,000. ABG wise pH 7.432, which is normal, PCO2 of 39, VBG actually, PO2 of 59.5, and BICAP 25.5, which is normal. And the total billy is raised 1.5 and direct billy 0.5, and the liver enzymes was normal. React.
What is the reason for that? What is the reason for that? Suppose it was 1.8. Bilirubin direct was 0.5. Child has no symptoms. You just accidentally discovered because there was vomiting. So you decided, okay, let me do the LFT. And if he did exercise or fasting, then his bilirubin was going up a little bit. Yeah, correct. So what is that condition? Gilbert disease. Okay. If you find accidentally mildly elevated bilirubin, which is indirect, and child is asymptomatic, then look for that. Also ask family history. Somebody in the family will have little bit higher bilirubins. Thank you.
IVIG was given for the child in for 2 days. Then the power is improving of the lower limbs, and MRI was uh, not planned, sir.
That's okay.
Typical usual symptoms of persistent vomiting not one but five for this 10 to 15 days. One of
10 days.
and vomiting headache relief power.
Again, a request, if you are not going to be there next Thursday, ask your colleagues to tell us what happened. We have never had even once a report on a following week. So we lose to know correctly what happened ultimately. And I think that's the only learning way. So please take a note that if you are not able to be here, somebody who is going to present must tell us. Okay, otherwise every time we have new people and we don't know what the old reports were there. So we are left to just discuss without coming to conclusion. So please take a note of that.
And we never learn. Which unit? Which unit is this?
Hello. Hello. Good evening, everyone. Hello. Good evening. I'm Dr. I'm Dr. Karan, and I will be presenting the short case today. Aditya, 6-year-old male child, second by birth order, born out of non-consanguineous marriage. Sorry, sir. Six-year-old male child, second by birth order, born out of non-consanguineous marriage, hailing from Alibag, Hindu by religion, uh, bought by parents, came with a complaint of bilateral lower limb pain for 6 days and rash present over the body for 3 days. So the child was all right 15 days ago. The child developed fever, which was intermittent, more during night time, undocumented, not associated with any relieving or aggravating factors. Child was active in the interfebrile period. It was not associated with any chills or rigors. Child received outside medications, but the outside medications were not known to the parent. He also had some cough, which was non-spasmodic, non-paroxysmal, not associated with any post-stressive vomiting. It was neither associated with any increased work of breathing. After taking the medications, the child was symptom free for the period of 8 days, after which the child developed bilateral lower limb pain, initially the knee pain, which progressed to ankle, then involving the hip, which was associated with dull aching pain of mainly the quadriceps and the calf area. Uh, the pain progressed. Now the pain was associated with difficulty for the child to get up from sitting position and even difficulty in walking. The pain progressed to the upper limb. The pain in the upper limb started at the elbow, then at the wrist, such that the child was not able to hold his pencil, neither was he able to eat food. After 5 days, that is after 5 days of developing the weakness, uh, the child developed non-itching rash that appeared first on the extensor surface of the elbow, of the right elbow, later involving the knuckle, followed by bilateral cheeks and over the bilateral eyelids. There is a history of decreased oral intake. There is no history. There is no history of swelling. There is no history of weight loss. There is no history of cox contact or insect bite or any drug consumption. There is no the pain is not associated with any diurnal variation. There is no history of diarrhea or trauma or having canned food or honey consumption. Past history, there is no significant past admissions. ANC is normal. The mother has taken calcium and folic acid supplements. Birth history, full term, normal vaginal delivery. Child cried immediately after birth. The birth was 2 kg, but there was no NICU stay. Child was discharged on the day of life 5. Immunization is still 5 years. Development, he goes to Anganwadi. He is taking calcium multivitamin supplements. Developmentally, he is appropriate for age. There has been no complaint of any delay. Diet, he's having mixed diet. Impression, a 6-year-old male child came with a complaint of bilateral lower limb pain with fever.
Hello, am I audible now? No, yeah, probably yes, yeah.
Yes, sir, you are audible. You are audible.
Fever for a week without much localization, declining trend, rising trend, same trend, every day one spike, two spikes, anything like that? any localization that took place in those 8 days? Because 8 days is a period long enough for localization to take place. Either an declining trend, inclining trend, anything much more detailed, because otherwise we are left just with the fever without a diagnosis, a manifestation. So
The mother told that the fever was increased during the night time, and apart from that, because of the cough and cold, they thought it was a
during the day when there was no fever, he was active.
child was active. Child
So
never
not
lost.
a very significant troublesome fever, which would come during night, which the mother took notice of. And throughout the day, the child was relatively all right, no fever, and maybe even active. So 8 days was a little longer time, but so far no localization, neither declining trend nor rising trend. So we'll just keep it at that. We are not able to conclude something more than, but this is an unusual manifestation of fever. By 7, 8 days, either I will expect the fever to have gone up, giving rise to something else, or should have subsided by now, or some other manifestations, localization should have come, but just the fever. Okay, okay. And child was symptom free for 8 days after that. Okay, so some medication symptom free, but the only symptom was fever and maybe some cough and cold, which we just take it as uh, some associated manifestation, and symptom free for a period of 8 days, after which the child developed bilateral lower limb pain, initially knee pain, which progressed to ankle, knee joint, and ankle to hip, associated with dull aching pain, mainly quadriceps and calf muscles. Now, what does it? Was the pain limited to the joint, or she says sab ye dukta tha, the entire leg was paining, or it was only the joint?
Ankle and the hip, and later the whole the muscular part also, the muscle part also was involved.
Okay.
Quadriceps
Why
and
did she
knee.
think that it was mainly during the knee? That means only the movements of the knee were painful, and otherwise the child's limbs were not painful. One does not know whether the pain involved the entire limb and she attributed to the knee, or it was really restricted to the joints first, and involvement of the other part of the limbs came up little later. But let us, there was never any swelling. So there was never any swelling of the joint, no arthritis, maybe arthralgia, and there was no jumping from one joint to another. So there was arthralgia and muscle pain. So maybe there was no significant only joint involvement, and therefore there was myalgia, arthralgia, and rash which developed later on, or maybe earlier. Yeah, developed bilateral left knee pain, which progressed to ankle, knee, and was associated with dull aching pain mainly in the quadriceps. Was there associated weakness? Pain was associated with difficulty in getting up from sitting position and difficulty in walking. Was this difficulty in getting up and walking due to pain or due to weakness or due to both? Because if I have significant pain in both my joints as well as limbs, then I don't know, I am not walking because of the pain or because of weakness or both. In other words, at that time you may ask whether when the child was in lying down position, will he move the legs? If it was pain, he would not like to move the legs even during lying down position. But he was able to raise the legs, he was able to move, but was associated. So want to distinguish between weakness or pain or both. And was it restricted to the joint or it was all the way? There was no associated involvement of bladder bowel. So for the time being, since he started with pain in the entire leg, I would say that it was leg pain in both the legs associated with joint pains, which was a manifestation of the generalized pain, and not, I would not think of joint pains as the first manifestation. Okay, so let's do that. If it was joint pain as a first manifestation, then a rheumatological disease giving rise to involvement of the muscles, etc., is not very common. The joint pain will often remain restricted to the joint, though other joints may be involved. Rash can occur in a rheumatological disease. So debating between the two, I thought maybe a limb pain more noticeable by the mother in the joints. Okay. And then the limb pain was on after 5 days, no, or there was a rash in one lower wrist, such that there was difficulty in holding pencil and eating food. So the difficulty in holding pen and eating food was because of weakness or pain. The difficulty was as a result of pain, or suppose I have pain in my small joints, then I can't hold a pencil and I have difficulty in feeding. But if I have weakness, also the same thing happens. What was that? We don't know that. Pain, it was involved in the wrist. Yeah, so it was the pain. So pain everywhere in the muscles and joints, I mean, getting worse with time, involving even the small part of the body, including the hands, and a rash are the manifestations preceded by fever with an intervening normal period. Now we have seen that fever and intervening normal period and manifestation later on are usually an immunological disorder. So probably an immunological disorder, but involving what? Involving all the limbs, including the muscles and the joints. Maybe the joint, specifically joint involvement in the form of arthritis was not there, because there was never a swelling of the joint. So I think generalized pain, including the mother, may have been attributing it to the joint also. And associated rash often tells you that it is likely to be of immunological origin. What are these rash and pain as a man? Which are the diseases which we can get pain and rash? Step. Eyelids.
Usually involving the extensor surface of the right elbow, then and then bilateral cheek and the eyelids.
Cheeks. Boy, no? Not a girl. Okay. So that means there is element of myositis, and because in children, uh, only myositis doesn't occur. It often is dermatomyositis only, and is associated with pain, rash, and muscular pain. So had all of them, one after the other, and they were relieved by medication or no? No. So he came to you with this.
Yes.
So he came with dermatological and muscle manifestations as a dermatomyositis, and preceded by fever. Can streptococcal rash be like this? He may not have complained of sore throat. He had streptococcal rash, and now the streptococcal rash has come. We don't know whether it was sandpaper-like or anything like that. Can it be a manifestation of that? Pardon me? Scarlet fever. Because it's important. There is treatment. If you don't treat, then it will give rise to cardiac involvement. I think the scarlet fever manifestations come when the child has actually sore throat, and as a part of severe tonsillitis, as he progresses and he does not improve with treatment, then the scarlet fever or other bad manifestations of streptococcal disease, maybe even requiring IVIG to control the infection, not a gap in between the two. So this particular thing was probably not, as an acute manifestation of fever, it is not there. I think we settled down with the diagnosis of dermatomyositis, acute dermatomyositis in a child like this.
I think in a typical dermatomyositis, there could be a weakness of muscles as well. So it's not only the pain. And many times, as the time goes, the pain is not a presenting feature, but the weakness is present in patient. And of course, you get the story. Again, 8 days of fever, non-localized, getting better by itself, must have been a part of that immunological problem. The fever is never continuous. In fact, the muscle weakness starts appearing more and more, and the pain possibly getting less and less, and therefore they may present even with weakness. But of course, preceded by this kind of a story, right? Can we have a quick look at the patient so that everybody will see that?
Much dermatomyositis these days, or we don't see much dermatomyositis these days.
Possibly, to me, SOGI, Elise, and next comes the dermatomyositis in order of prevalence.
JDM quite regularly, actually. That comes as a standard case also in the exam, and I mean everywhere. JDM not considered. I mean, for general pediatricians like us, it may be rare, but it's like one of the, and to get this kind of classical presentation.
I think if you look at the rheumatological disorders, these three always are, mine. One is a SLE, one is a GIA, and one is a dermatomyositis. Mostly it will cover 90% of all that. Yes. And Kawasaki, of course, yes.
Associate with fever. The rheumatoid arthritis, polyp, etc. Fever is not a major manifestation. Joint. Here it starts with a 3-4 disease, and which SOGIA and Kawasaki are important not to miss. Why? You may miss other things, but don't miss SOGI and Kawasaki. Yeah, severe cardiac involvement associated with systemic symptoms. So not to worry about, not to miss that. Now सांग, मोठ्याने सांग. मला ऐकू येईल एवढ्या मोठ्याने सांग. नाही? बर. अरे वा, शाबास. आता असा हा पाय आहे ना उचलून दाखव आणि परत हे बघ. असा कर आणि असा करून दाखव. आणि खाली ठेव. हा पण कर आणि खाली टाक. शाबास. पूर्ण पाय उचलता येतो का? असा अख्खाच्या अख्खावर उचलता येतो का? नाही येत. अख्खाच्या अख्खा नाही. हात वर कर. वा. Yeah, there is weakness. He has good extensor power, but he was perhaps either not cooperative or much in the
15 days now.
it improved a lot.
Yes, sir.
Yeah.
He has received
No,
3
we
days of
understand that.
methylprednisolone. Then he is on predni right now and methotrexate. And prednisone.
Time is so much. Only myositis now does not metallurgical myositis. In children almost always there. Clinical photographs taken. तसं नव्हे पाहिजे. हे बघा, इथे दाबलं किंवा इथे हलवलं तर दुखायचं का इथे दाबलं तरी सुद्धा दुखायचं. म्हणजे फक्त सांध्यालाच नाही, पोटीला पण दुखायचं, इथे पण दुखायचं, इथे पण दुखायचं. आता बरं आहे. असे ओठ पण लाल झाले होते. आतमध्ये जीभ लाल, खायला त्रास होत होता का असं नाही? ग्लुकोज आवाज आला. डोळे लाल झाले होते, चिकटायचे सकाळी. व्हेरी क्लिअर अबाउट इट. आता बरं आहे ना, मग आता बरा झाला, पळा आता, मग लवकर घरी जाणार.
So over the last 15 days, the child has received 3 days of methylprednisolone, and rest she is on tablet predni right now. And we have started on methotrexate. Our plan is to, and the myositis profile, different anti-Jo, anti-SM antibodies that we had seen actually had come negative. So our plan is to do an MRI and a muscle biopsy. Like,
The rheumatologist is consulted.
so, adult rheumatology team has seen the child. They are also suspected.
Any X-ray you have? Have you done any X-ray?
Yes, sir.
Sometimes at the most prominent, though this is an acute stage, in chronic stages you might see myositis ossificans. This one you can see calcium deposition basically, not typically myositis. In JDM you can see calcium deposits in the muscle in the later part. Maybe not.
Sir, right now I don't have the X-ray.
That's fine.
I will definitely share it.
That's fine. Thank you.
Sir, between MRI and biopsy, sir, what is the take?
I'll ask you a very gross question. If I have to do MRI and biopsy on you, sorry. So MRI, no, I get your point. Of course, apart from being non-invasive, MRI classical picture is supposed to be diagnostic of JDM. So if you have muscle involvement like this, probably you will get the answer. And that's why you may not need a biopsy. But if you don't get picture, then biopsy will have to be done subsequently. The GBS MRI are more for variants. If you don't, it does not fit into typical GBS, then you would do it. Otherwise, from cost point of view or from management point of view, MRI will not add anything in GBS. So one may not do in GBS. Like how he said, if you got antibodies positive, cost is a concern, you have a clinical picture, even for JDM, you may not do an MRI. Dr. Palniraman is asking inflammatory markers. Yeah. They came negative, Dr. Palniraman. But CPK is 4073. So that's important, right? Anyone else has CPK high in the family? No. Because 4000 is high. And this is before giving methylpred or after giving methylpred? Before. So that's fine. Which are the other muscle enzymes that you can check apart from CPK? Which muscle enzymes get elevated? Dr. Palinaman, you are not supposed to answer. Yeah. So SGOT, LDH, CPK, and aldolase. These are the four which generally represent muscle injury.
Anybody has questions to ask, please? You saw the rash, so very typical, well taken clinical photograph. Please note the eyelids, also the cheek, and also note the lower lip, which shows that there is redness, mucus involvement. You have taken the photograph, the knuckles. So I think we had two very nice cases with the diagnosis definitely in one and probable in another. We'll be little wiser next time. Okay, you will please let us know. And we meet the next Thursday as you. There's nothing that is. So, oh, what is? Or is the yeah, is closed or okay? If it is closed, then let us know that we can circulate. Otherwise, we meet as planned. Thank you very much.
Thank you, Amdekars sir.
Online viewers, you want to add something, Dr. Palni Raman?
Nothing, madam. Nothing, madam.
Not audible. Okay. Thank you. Thank you, everyone. Thank you, online viewers. Thank you, everyone.